All right, there we go. All right, so week nine. Um, so week nine, we're going to talk about functional ability, physiologic changes, and medications. So this is going to be in your basic geriatric nursing text. It's chapters 3 and 7. And then in your concepts of nursing practice, it will be chapter 2. Um, and then everybody um, has anybody been attending the reviews for exam 3? Yes, awesome. Perfect. So those are in progress, and as they come in, I have been posting them in your announcements so that if you want to go back, um, and review those prior to the exam, then they're there and available to you. Um, so we're gonna go ahead and get started. I don't know where everybody else is because we're like I said, we're still missing quite a few people. Um, oops, we got some more coming in. Um, all right, let me share my screen. All right, so there we go. All right, so everybody can see the PowerPoints. Yes. Okay, cool. All right. So again, this is going to be your basic geriatric nursing chapters 3 and 7, and then your concepts of nursing practice. It'll be chapter 2. Um, so when we look at what do you call it? Um, the functional ability. So definition of functional ability is the individual's ability to perform normal daily activities, right? So our ADLs. So the physical, psychological, cognitive, as well as social abilities to carry out those daily activities to meet their basic needs, right? So this could be, out in the family, it could be out in the community, it could be in the workplace. And so it's just basically the adaptive dimension of development, right? So it has a big impact on independence and quality of life. Health, according to the World Health Organization, the World Health Organization defines health as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. So with that being considered, with that taken into consideration. So nursing interventions. We think of our older people, again, not everybody's desire, right, is to be put in a nursing home and taken care of for the rest of their life, right? We want to try to maintain our independence as long as possible. So there's two terms here. We have our ADLs and we have our IADLs. What's the difference between ADLs and IADLs?
One is assisted and one is independent.
Right. Okay. Yes. Sorry, I couldn't hear what you said. So yes, your ADL is bathing, dressing, showering, eating, toileting, mobility, transferring, right? And then our IADLs, right? These are like managing your finances, your medications, going to the grocery store, driving, right? Housework, right? Using the phone. So there is a difference between your ADLs and your IADLs. And so as nurses, right, we have to look at both sets and determine the amount of assistance that they need, the amount of time needed and their level of performance, right? So as a younger person, right? taking a shower, maybe 10, 15 minutes, right? As an older person, some of those activities may take a little bit longer. Especially when we look at managing finances and medications and grocery shopping, transportation, right? How, are they still able to drive? How well are they to get around the grocery store, right? To do their shopping, um, providing adaptive equipment. Um, what are some examples of adaptive equipment?
Walkers, canes, wheelchairs.
Okay, walkers, chains, wheelchairs. What else do we have available?
Um,
Would that be like
Adaptive
hearing
equipment like
aids,
food,
cell
so
phones and stuff?
Okay,
eating
like even
utensils.
utensils, those little grabby things. I don't know what they're
Hmm.
called, but those little grabby things are awesome, right? There's things to help them put their socks and shoes on. Have you guys seen those? The little sock thingy. I don't know what they're called, but they'll always be the little sock thingy to me, right? Um, there are adaptable phones, just like Joseph said, that I mean, you can even do it with your regular cell phone. You can make like the numbers, right? Everything much bigger so it's easier to see. Um, they or even less complex as much as um rather than using one of the smartphones like the iPhone or the Android, right? They have some of the older type flip phones, right? That may be a little bit easier to use. Really just depends, right, on their abilities, but having those big so like where I work, they have phones in all the residence rooms, and they're like the ones that have the really big numbers on them, so like they can see the numbers really clearly, use the phone as easily as possible, right? So making some of those adaptives, um trying to think what else I've seen. But there's lots of different types of adaptive equipment that are out there. And all of the purpose of that adaptive equipment, right, is to keep them functioning as independent as possible. So with chapter 3, the physiologic changes. All right. So we look at studying for the exam as well as for your HESI prep. Each body system includes 3 sections. So the overview of the system, so your basic anatomy and physiology, um, the expected age-related changes. So when you look at the expected age-related changes, make sure you're looking at those tables that are in your chart, with some of the common disorders that we see with aging. Again, you can use the tables to make flashcards, that kind of thing. And then as some people are really good with this, making concept maps to help you understand the disease processes. Again, I'm not a concept person. I love flashcards and I love color coding my notes. So, whatever works best for you as you are studying. Um, some of the common features across the organs, as we get older, unfortunately, um, things generally tend to decline in function. So there's generally a decreased cell number and function. There's changes in tissue structures. There's also increased chronic inflammation. So these are just common features across some of the organs. So musculoskeletal changes. Musculoskeletal changes is table 3.2 in your textbook. I think it's page 39. So, all right, so let's do some matching. All right, so we have decreased bone calcium, decreased fluid in the intervertebral disc, decreased tissue elasticity, decreased muscle mass, and decreased blood supply. So Decreased blood calcium would lead to which one of these? Decreased height, decreased mobility and flexibility, decreased strength due to leading to falls, diminished muscle strength, or decreased bone strength leading to osteoporosis.
I'll
The
see you.
last one.
Osteoporosis.
All right, so we have decreased bone calcium lead to decreased bone density. All right. What about decreased fluid in the intervertebral discs?
Mobility slash flexibility.
Mobility slash like what do you
I
call
would
it?
say decrease to height.
Decreased height.
All right. So decreased height.
Oh,
De decreased tissue elasticity.
Mobility and
And flexi.
flexibility.
Okay. Decreased muscle mass.
Diminished
Diminished
muscle
muscle
strength.
diminished
strength.
strength.
Okay. And then decreased blood supply.
Decrease in strength leading to
Leading
falls.
to falls.
All right. Let's see. Ta-da. So yes. Decreased blood supply leads to decreased bone density, which leads to osteoporosis. Decreased fluid in those intervertebral discs will lead to decreased height. Decreased tissue elasticity, decreased mobility and flexibility, decreased muscle mass leads to decreased strength, leading to falls, and blood supply leads to diminished blood.
Mm.
Can't even speak, diminished muscle strength. So, osteoporosis. All right, so we already talked about that. We have decreased oh my gosh, decreased bone calcium, right? So excessive loss of calcium from the bone combined with insufficient replacement results in osteoporosis. All right. And so lots of people have osteoporosis. Um, it is going to be more common, right? Especially as the population continues to age, right? Those baby boomers. So they have porous, brittle, more fragile bones that are susceptible to breakage, right? So increased porosity, weak and brittle bones. Spontaneous fractures of the vertebrae or other bones can occur, even with absence of trauma. Like they don't even have to have they don't have to fall in order for these bones to break. Um, like spontaneous hip fractures can lead to a fall, right? Rather than the fall leading to the fracture. It is diagnosed through a DEXA scan. Risk factors, being female, of course, is going to be one of the biggest ones, right? Especially postmenopausal women, right? With the decreased estrogen, being Caucasian or Asian, having a small body frame. Again, like I said, menopause, being postmenopausal. If there's a family history of osteoporosis, that also puts you at a risk. Um, Lifestyle factors, lack of exercise, immobility, excessive alcohol consumption, cigarette smoking, deficient calcium and vitamin D, um, diabetes, hyperthyroidism also put you at a risk for osteoporosis. Long-term use of medications like your um, phenytoin that we use for seizures, heparin, antacids, proton pump inhibitors. So the long-term use of proton pump inhibitors, if you remember, those are like your prazols, your omeprazole, your esomeprazole, your pantoprazole, which is your Prilosec, your Prevacid, your Protonix. Um, they put you at a risk for osteoporosis, which is why we don't like people to use them for long periods of time. Oral corticosteroids also do that. Your chemo drugs put people at risk as well. Um, and then even diseases like celiac and inflammatory bowel disease, having weight loss surgery also puts you at risk for osteoporosis. weight loss surgery and the GI issues, it's generally because of absorption disorders, right? We're just not absorbing all the nutrients like we should. So we look at more age-related changes. Right. So here's a normal disc, and then here is an older person's. So you can see there's significant difference, right? Loss of height does occur. Um, so it could be the result of the osteoporosis. They also could develop something called kyphosis, which is this abnormal curvature here up at the other part of the spine and the thoracic spine, kind of gives them a humpback appearance. Um, I actually had a resident. This was long forever ago. I was back when I was an LPN. Her kyphosis was so bad that it was almost at a 90-degree angle. She couldn't even lift her head up. Like, so when she would, and she was still ambulatory, and she would still walk, and we had to put little mirrors on her walker, so that she could see in front of her. Um, because like she would literally be facing the ground. And so she, this because of the kyphotic changes. So we put mirrors on her walker so she wouldn't run into things, especially other people in the hallway. Um, I don't remember. I just remember she was a poor surgical candidate, which is why she had never gotten it fixed. Um, but some of those kyphotic changes can be really severe, which leads to the reduction in height. So, um, I have a coworker that used to be 5'9", and now she is 5'4", just as a result. Yeah, just as a result. She also developed, what do you call it? Oh my gosh, scoliosis, as she got older too, which also helped to increase the height loss. So comparing and contrasting some of the other musculoskeletal disorders. So again, here we have osteoarthritis, osteoporosis and rheumatoid arthritis. Again, osteoporosis, right? Or osteoporosis, we have fragile bones that are weak, that break. Um, with osteoarthritis, that's the most common form of arthritis. It is not a normal change of aging, right? But the risk for osteoarthritis does increase with age. Um, and so women do tend to get um, osteoarthritis more than men. Don't really know what the cause of osteoarthritis is, but there are risk factors: age, obesity, joint injury or overuse, family history, weak muscles, and like I said, being a female. People, even like, working, on your, what's the word I'm looking for? Certain jobs, right? Where you're, using certain parts of your body all the time, right? And you get that overuse can lead to um the osteoarthritis. It's asymmetric, okay, which means that it doesn't have to be in both. It can be in just one side. So you can have, osteoarthritis in one hand, not both hands. Um, so when we look at treatment for osteoarthritis, exercise, your weight bearing exercises are actually really good for arthritis as well as osteoporosis. Weight control, protection of the joints, so may need some braces or some splinting. We can do some PT and OT and NSAIDs, and your corticosteroids are the treatments of choice. The corticosteroids, we can do the injections right into those joints, right, to help with the inflammation. Um, with your rheumatoid arthritis, this is a collagen disease. It's an autoimmune disorder. It causes inflammation of the synovium, as well as damage to the joints, and the cartilage. And so again, this is an autoimmune disorder. It does affect women more than men. Um, nice, right? So they do get flares. So like let's say there's a difference. So in osteoarthritis, okay, wake up in the morning, I may be a little bit stiff and whatever joints affected, right? But usually by moving and manipulating the joint, the stiffness goes away. With rheumatoid arthritis, the stiffness doesn't go away. It can last and be continuous. It is also more symmetric. Okay, so it's going to affect both hands versus just one or the other. And then it is worse after rest, right? You stop moving, and that stiffness, that pain is going to be worse after rest, but it will be relieved with movement. Um, with your treatment, we have NSAIDs, aspirin, ibuprofen, naproxen. We can use corticosteroids like prednisone to reduce inflammation, right? But what are some of the concerns with using corticosteroids for long periods of time?
Constipation.
Okay, constipation. What else do yeah. What else do corticosteroids do?
You could become like they raise your blood
Addiction.
sugar.
Can
Can it
elevate your blood
cause
sugar.
rebound? No, that's something else. Never mind.
So elevated glucose levels. It also um, increases susceptibility to infection, right? It has definite changes to the GI tract. Long-term use can lead to osteoporosis, right? And so even in somebody that does not have diabetes, it can cause those elevated glucose levels. Doesn't matter the cause of the elevated glucose levels. If you have diabetes or you don't have diabetes, long-term elevated glucose levels can still cause end organ damage. Okay, so we don't like to use those corticosteroids for long periods of time. We have the DMARDs, which are your disease-modifying anti-rheumatic drugs, right? Your cyclosporin, your zithroprin, sulfasalazine, hate that word, methotrexate. These are all used to um, slow the disease progression, right, to preserve joint function. We have biologic agents, like your MABs, like infliximab. We have etanercept. I'm trying to think of what else we use. Um, adalimumab is another one of our biologics, right? They interfere with the production of the inflammatory chemicals by the body. So there's quite a few drug medications out there where we don't necessarily have to use, right, those corticosteroids. Now, we may use them for short periods of time during like acute flare-ups. Other things, there are some surgical procedures that can be done if the joints get really bad. Like we can do, joint replacement, things like that, to help with the pain as well as to increase function. With the cardiovascular system, some big changes, even within the cardiovascular system. So the heart, um, we have decreased muscle tone, we have decreased cardiac output, we have decreased elasticity of the heart muscle and the blood vessels, increased hardening of the arteries with it, which is your atherosclerosis, right? Resulting in increased risk of heart failure, right? Because if my heart muscle tone is decreased, right, that means that my heart has to work harder in order to get blood, right, to the rest of the body. And if my heart has to work harder, then that does increase the risk for heart failure. Decreased cardiac output leads to decreased blood flow to the extremities, right? So think of that peripheral circulation, getting blood down to the tip of the toes, the tips of the fingers. The increased risk of coronary artery disease, hypertension, and heart attacks, right, is related to the decreased elasticity of the heart muscle and the blood vessels. And then the increased risk of peripheral vascular disease as a result of that atherosclerosis, right? So atherosclerosis is the hardening of the arteries. And then if we add in, if they have high cholesterol, right, maybe they have some plaque buildup within those arteries, which could even cause worsening, right? So heart failure. So we have two different types of heart failure. What are the two different types of heart failure?
Congestive heart failure
Okay. So
and uh,
And heart disease,
I
right?
just had that.
And what is it? MR? MI?
so heart failure, right and left. Not wasn't trying to play a trick, wasn't a trick question, but we have right and left heart failure. Right, left, oh my gosh, can't even say it. Right and left sided heart failure. All right, so if the right side of my heart fails, what are the symptoms? If the right side of my heart isn't working great, where am I going to see those symptoms?
In the lungs.
You kind of mixed up.
Speech.
Oh,
In the
like
body?
in the body.
In the
Right,
body,
in the
right?
periphery, right? So that's where you're going to see things like your peripheral edema, right? Your jugular vein distension, right? Your portal hypertension, right? The blood is backing up into the rest, because think of it, right? Where does blood come from? Comes from the periphery, comes into the superior vena cava, dumps into the right atrium, right? So the blood is coming from the body. So if the blood isn't coming back like it should, it's going to build up in the periphery. If the left side of my heart isn't working, where are my symptoms going to be?
Lungs.
Respiratory.
Lungs. So L, right, left lung. So if the
Okay.
left side of my heart isn't working, right, where does that blood come from? That comes from, right, goes into
No.
the right atrium, from the right atrium to the right ventricle through the pulmonary veins or pulmonary artery into the lungs, right? And then the lungs dump into that left atrium. So if my left ventricle isn't pumping the blood out to the body like it should, right? That's where you're going to get those pulmonary symptoms, right? The shortness of breath, the orthopnea, what we call, we can get the paroxysmal nocturnal dyspnea as a result, right? Eventually, what happens though with heart failure, regardless if the right side of my heart is failing or the left side of my heart is failing, eventually both sides are going to fail, right? Because it's just inevitable. So again, some of those signs of heart failure. You have your shortness of breath or dyspnea with exertion. We can have the orthopnea. Orthopnea is shortness of breath at rest when they're laying down, right? So people with heart failure, even like your COPD patients, right? It's easier for them to breathe when they're sitting up, right? Even sometimes leaning over. Coughing or wheezing with exertion or even at rest. Doesn't really depend, just depends on the severity of the heart failure. Fatigue, weakness, generalized muscle weakness, your peripheral edema, weight gain is another big thing. Weight gain is a result of fluid retention. What is the number one way to evaluate fluid status? Anybody know? I know, like the way Katrina
Daily
just looked at
weight.
weight. Absolutely. So weight, how much does 1 liter of fluid weigh? Anybody know? Anybody know? I can't even talk. I don't know why I'm stuttering. 2.2 pounds. Or I'm sorry, 1 pound, 2.2 kilograms. Okay. Or no, 2.2 pounds. I was right. Um, So that is why when we have patients that have heart failure, we do daily weights, right? Same time every morning in the same clothes, around about the same time on the same scale. Other things, they may experience nausea, vomiting, anorexia, or not having much of an appetite. And of course, that paroxysmal nocturnal dyspnea. Again, that's that, can't really breathe while I'm laying flat, right? So we need to sit up and breathe. Um, there's also some changes in heart rate that occur. Um, Again, the shortness of breath. So fluid and electrolytes with heart failure. So we talked about fluids, right? That's one of the biggest things. If my body isn't able, to continue to pump the blood, right, that may lead to decreased perfusion to the kidneys, which ends up causing the fluid retention as well. And if the fluid isn't coming back to the heart like it should, or the blood's not coming back to the heart like it should, it will, eventually fluid will leak out into the peripheral areas, right? So like your ankles, particularly, is where we see that pitting edema, the portal hypertension, and one of the big things that we will do is put them on diuretics, right? Um, and diuretics are going to help to pull some of the fluid, right, and bring it to the kidneys to let it out. So that will increase their need to use the restroom. When's the best time to give them their diuretics?
In the morning.
Right? Give diuretics first thing in the
In the
morning, right?
morning. Oh, yeah.
Yep. So they're not up all night peeing, right? With your Lasix, which is a loop diuretic, right? We really pay attention to sodium and potassium, right? Potassium is one of the big electrolytes that we will use when we are using furosemide or your loop diuretics. So we have to monitor their potassium levels very carefully, right? Potassium levels get too high, potassium levels get too low. Either way, right? Potassium is one of those we got to really keep it where it needs to be, because it can lead to dysrhythmias as well as fatal cardiac events. Other meds, digoxin is another one. Digoxin, um, with heart failure again, right? We're not getting, heart's not pumping effectively to, get blood flow to the body. So it works harder, which increases the heart rate. So we give digoxin. Digoxin's a great drug. What it does is instead of giving us, 100 like measly pumps, we're not really getting a lot out. It's going to slow that heart rate down. So we're going to get more of a pump every time we pump at a slower rate. Um, if we have to use digoxin and furosemide together, we have to even make sure that we're monitoring those potassium levels even more closely, because low potassium levels can increase the risk for digoxin toxicity. What else? Cardiac injury, your heart attack, or your myocardial infarction, your congestive heart failure, whatever you want to call it. They may not have the classic chest pain that you may expect, right? The left shoulder pain, the pain in the jaw. Some of the symptoms might be a little less obvious. They could have nausea, fatigue, confusion. They may feel like there's an elephant sitting on their chest, and that is something that you will hear them say. They feel like something is on their chest. So it is very important that we recognize that the symptoms may not be um, the same as what we would see in a younger person. And then even with female patients, sorry, um, female, females don't always present the same way. And so we have to pay really close attention to the fatigue, indigestion, the nausea. They also may have just like cold sweats. Some women may, they get the shoulder pain, the jaw pain, but a lot of times the symptoms that women have are atypical. They're not what we would see generally in somebody that we would expect to see somebody in that is having a heart attack. We look at respiratory changes. Um, Lots of respiratory changes that occur as well with the older adult. We have decreased number of cilia, decreased strength and endurance. What else? Decreased lung capacity. We have increased calcification of cartilage, decreased number of macrophages, decreased number of capillaries, decreased our tissue elasticity in the lower lobes is decreased, as well as gas exchange, which can lead to a pooling of secretions. Um, and so a lot of different things can happen with the older person. So with the decreased number of cilia, right, there's a decreased ability to trap debris that gets into the lungs. There's also a decreased cough reflex. So when that stuff gets into the lungs, right, it's harder for them to cough it back out. Um, with the decreased number of capillaries, right? That decreased gas exchange. So, that we're not getting as much oxygen in. Um, Trying to think, decreased strength and endurance. This is also another huge part of getting older. It also, with that, they have the decreased ability to breathe deeply, right? Take those really good, deep cleansing breaths. So even like post-surgical, having them cough in and deep breathing is going to be even more important to keep their lungs clear, the use of incentive spirometry, pneumonia. So pneumonia we know is an acute inflammation um, caused by either a bacteria, a virus, a fungi, could be a chemical or even mechanical. So if they were to aspirate some food, so the alveoli, the bronchioles, they will become clogged. And that decreases the ability of the lung, right, to exchange gases. Um, and it can, unfortunately, in the elderly, it can progress rather quickly. Um, you will hear, so this is your inflamed bronchiole. Here's your alveoli. The fluid builds up there. And this fluid can, what do you call it? Fill up rather quickly, which you can hear when you're listening or auscultating to their lungs. There are going to be significant breath change, sound changes that occur. So what are some of the symptoms that you would expect during inflammation?
It could be painful and like warm to the touch.
Okay, painful, warm to the touch. What else would we expect?
Redness,
Okay.
Fever,
Fever, absolutely. What kind of sounds do you think I would hear if I were listening to the lungs?
Would it be crackles?
Okay, we could have crackles. What else could we have?
Um,
What about some wheezing? Maybe some wheezing. Could have some wheezing.
Hello?
Okay. Um, say that again.
I'm in class.
Maisha, you're
I
not
didn't.
muted.
Oh, sorry.
So we could have fever. We could have increased white blood cells, right? Obviously, we're not going to see an increase of white blood cells, right? We would have to do some blood tests. Tachycardia, tachypnea, fatigue, cough, right? The elderly may not have high fevers related to changes in their immunity status. However, we still can see fevers in the elderly. It is possible. They also may have some pain with respirations or even shortness of breath. Has anybody ever had pneumonia? Yeah, it's not fun. Um, the sickest I ever got was always in nursing school. Go figure, right? The increased stress, the not sleeping, the not eating right. My first 9 months of nursing school, I had strep throat. I had strep throat twice, and I had pneumonia twice during nursing school. And so yeah, like it wasn't like somebody sitting on your chest. It was like every time I breathed, it just hurt to breathe. Um, Other things that we have. Oh, let's talk about tuberculosis. So, tuberculosis is caused by Mycobacterium tuberculosis, right? It's spread by airborne droplets. So, an infected person coughs or sneezes, releases the droplets into the air. And then, of course, those droplets can be inhaled by another person, right? And the little bacillus gets into their lungs, and then the disease spreads. This is more common in patients that have weakened immune systems, that are malnourished, that are living in crowded living conditions, poor sanitation, and having diseases like diabetes, cancer. Those all increase the risk for patient or for the elderly contracting tuberculosis. So symptoms is your cough, your night sweats, your fever, your shortness of breath. They also could have some chest pain, anorexia, and weight loss. The cough can be productive or non-productive with tuberculosis. It also can be green, yellow. It could be rust colored as well, which is the presence of blood. So it gives it that nice rusty color. Um, with trying to remember which one, with your um pneumonia or even COVID, right? Or flu, right? This is what you're going to see. The fever, the shortness of breath, yellow or green sputum, they increase white blood cells, they increase heart rate and respiratory rate, muscle pain, and then other, like COPD. It could be exposure to agents. They will also have the shortness of breath, the chest pain, the bloody sputum. So COPD, which is your chronic obstructive pulmonary disease, it includes your emphysema as well as your chronic bronchitis. They usually occur together, so they usually will have emphysema and chronic bronchitis together. It's common in those who have a history of smoking or have had a high level of exposure to environmental pollutants. Um, so, what are some of the signs and symptoms of COPD?
Cough.
Yep. Cough is
Shortness
definitely one.
You're perching, like, no, never mind. Barrel
shortness
chest,
of breath.
Shortness of breath. Yep. That's the shortness of breath or your dyspnea.
barrel chest,
Barrel chest. Yep. And the long-standing patients with COPD, they will definitely develop those barrel chests. Yep. Wheezing is another common one. They also can have some cyanosis. Talked about the risk factors. So what do we do? What do we do for patients that have COPD? What are some of the nursing interventions that we can help that can help with COPD?
Can't you put them on like a low amount of oxygen to help them?
We, all right, definitely do low flow oxygen. Why don't we want to give them higher flow oxygen? What if their O2 sats are all the way in the 80s? Why
Their
don't
body
we?
is used to that number. So if you get them a high, like say if you get them 6 liters of oxygen, you're giving them too much, so it's going to tell the
You
body
want
to
to
stop
overload.
breathing.
Yep. So patients that have COPD get used to um they're compensating. They've compensated for the higher levels of CO2. Patients that have COPD, one thing doesn't matter if it's asthma, emphysema, chronic bronchitis, they have no problems getting oxygen in. They can get oxygen in. Getting the oxygen in isn't the problem. The problem is getting the CO2 out. Okay. So the CO2 builds up in their body and they compensate. Their body has compensated for the higher levels of CO2. All right. And so if we give them high flow oxygen, that could actually suppress their respiratory drive.
Is
So
this
they're,
why is this why they're on BiPAPs in the hospital overnight? Like if they're there?
yep. Yeah, to keep them breathing. Yep. What else can we do for patients with COPD? What is she wearing?
Breathing treatments.
So we can do breathing treatments, right? Usually albuterol or Duo Neb, which is your albuterol and Atrovent mixed together. What else can we do?
Can't
Encourage
we stick
breathing
him up?
exercises.
Yep, sit them up and encourage what, Jackie?
Breathing exercises.
Breathing exercises. Go ahead,
We
Katrina.
can also educate them about the risk factors like smoking, stuff like that.
Okay, we can educate them. If they've got severe COPD and they're still smoking, probably a good idea to quit, right? Um, so yeah, all of those things, right? Sitting them up. Um, Other things too is they may get short of breath really easy, right? When they are, eating, when they're trying to complete their ADLs, right? So we need to alternate periods of rest with, activities so they don't get overly short of breath. Other things like making sure that they rest before eating. So, like I had the flu, felt like I had flu and COVID, so I felt like it just like doesn't want to go away. But think about it. Think about it if you're short of breath. So what if I told you right now, okay, um, to go run around your house 10 times, okay? And then I was gonna put a big old Thanksgiving dinner in front of you as soon as you walked back in that house. Would you be able to sit down and eat? Right?
No.
Right? The shortness of breath, right? You'd be like, I can't eat, right? Because no matter how in shape you are, if I tell you to run around your house 10 times and you're going to come sit and eat a big dinner, you're not going to be able to do it. All right. So imagine feeling like that every day. So we want them to be rested. We don't want them to be, we want them to be as decreased short of breath as possible when it's time for meals. Um, right, most of your COPD patients are cachetic, right? They're usually thinner. They're usually going to be slightly malnutritioned. They may even be slightly dehydrated because they're not able to eat and drink like they should. So like the 4 to 6 small meals a day, um, even using nutritional supplements like Ensure or even Carnation Instant Breakfast would be good for these patients in between meals, to try to get those calories. They have a disease. Okay, when you have a disease, you have an increased metabolic rate, right? So it means you have an increased need for calories, right? So we have to try to find ways to help that. We could also do, not just nebulizer treatments, but we could do inhalers. We also can do the inhaled corticosteroids to help decrease the inflammation in the lungs as well. Oops. Um, Fluids help to keep, help the kidneys filter toxins and medications. Again, like I said, sometimes it's hard, right? If they're really short of breath to eat and drink like they should. Oxygen, um, I don't know if anybody's ever had, a nasal cannula before. I have prior to surgeries, it's very drying to your nose. All right. So you'll see even with low dose oxygen, we will use humidification on those, right? Add some moisture to the air to prevent the drying of the nasal mucosa, right? Because if we get cracks, and inside, I don't know if anybody's ever had a crack in their nose, in the mucosa in their nose. It's painful for one, right? But it's one of our barriers for infection. So cracks in the nose can, allow bacteria in. Um, and we should encourage them to drink their fluids, as well, keep everything nice and moist and helps to, right? Fluids also, the more fluids we drink, help to lessen the viscosity of secretions, gets them, helps them easier, right, to cough up, especially with the decreased cough reflex that we see with the elderly. When reviewing, I like this question. When reviewing a discharge plan for a client with COPD, the nurse should anticipate the client will do which of the following. So for one, what's the topic here? What are we asking about?
If the client has any education on COPD when they go home, as far as taking care of themselves.
Okay. All right. So when developing that plan of care, or when developing a discharge plan to manage the care of a client with COPD, the nurse should anticipate the client will do which of the following: develop infections easily, maintain current weight, require less supplemental oxygen, or show permanent improvement. I think I heard a B, I'm not sure. C. Okay, sorry. I heard it, I just didn't know what it was. Anybody? Just to see? Develop infections easier. All right, so they do tend to develop infections easier just because of the structural changes that occur within the lungs. So client with COPD is at risk for development of respiratory infections. COPD is a slowly progressive, therefore maintaining current status and establishing goal that the client will require less supplemental oxygen or unrealistic expectations. Treatment may slow progression of the disease, but permanent improvement is highly unlikely. All right. An elderly client has been ill with the flu, experiencing headache, fever, and chills. After 3 days, she develops a cough productive of yellow sputum. The nurse auscultates her lungs and hears diffuse crackles. How would the nurse best interpret these assessment findings? So we had the flu, okay? She had the headache, the fever, and the chills. And then after 3 days, she develops a productive cough with yellow sputum. So and she's got crackles in her lungs. What do we think has happened?
She developed pneumonia.
Pneumonia?
Pneumonia. Yep. So headache, fever, and chills, develops yellow sputum. We hear crackles. All right. So how would the nurse best interpret these findings? So it is likely the client is developing a secondary bacterial pneumonia. So Very good. Yes, pneumonia is the most common complication of influenza, especially in the elderly. So the development of a purulent cough and crackles may be indicative of a bacterial infection, not consistent with the diagnosis of influenza. And unfortunately, yes, it is a huge complication when it comes to um, influenza, especially the older adults, um, just because of the changes within the respiratory system. It is very common for them to develop pneumonia. It is common, it can happen in anybody, but especially in the older adults. And then we have our wonderful GI tract. And I say wonderful because the older person, they are very obsessed with their GI tracts. Um, so,
They're obsessed with pooping.
oh, they are so obsessed. I just don't know. Can't even explain it. They're so obsessed with it. But the stomach is lined with that mucous membrane, which helps protect it, right? Helps protect damage to the muscle walls. So we have the hydrochloric acid. Um, so we have decreased the adult, oh my gosh, the older adult will have a decrease in their gastric acids or their gastric secretions. Um, Medications damage the protective mucosal lining as well within the stomach. Um, and so NSAIDs, like your aspirin, your naproxen, ibuprofen, especially. We tend to use more Tylenol in our older adults than we do like the ibuprofens. Um, Iron supplements, corticosteroids can all be very irritating to the stomach. What can, somebody already said it, they're very obsessed about their poop, but what do iron supplements do to our stool?
It binds you. It makes you constipated.
It makes you constipated. What else does it do to the color?
They
It
turn like a
changes
tarry
it.
brown.
Yeah, they get those tarry black stools, and if they're not aware of it, they can think that, oh my gosh, it's blood that, and yes, lots of education, lots of education. Elderly also, they don't present the same, as far as illnesses go within the GI tract either. Um, it's so much is different. But generalized pain, decreased appetite, weight loss, nausea, vomiting, tarry stool would be some things that you may see. But yes, and I'm gonna 100% agree. I don't remember who said it because I couldn't see who said it, but they are obsessed with their bowels. Not everybody has a bowel movement every single day. Some people have one every day, some have two a day, some go every other day, right? But it's one thing that they can still, especially in long-term care, it's one thing that they can still maintain control of. So they try their best to maintain control. If they don't have a bowel movement, they get very upset. It it really bothers them. Um, and so, a lot of, with all the changes that go on within the GI tract. The decreased muscle tone at the sphincters, the decreased gastric secretions, the decreasing gastric motility and peristalsis, the medications that can increase the risk for constipation, all of those things. Um, so they do get very obsessive. So that's why most of your older adults are going to be on some sort of a stool softener, something like Colace. They also may be on Miralax, right? Or one of the other, like I've seen Miralax, I've seen Citracal. What's the other one? There's another one that they may be on, right? So they'll take those every day to encourage those bowels to keep moving, so that doesn't stress them out. But again, that is one thing that they still have control over, right? So they are going to try to maintain control as much as possible. Diabetes and your endocrine. So diabetes is probably going to be one of the most common disorders that you are going to see, as far as endocrine goes, and you're going to see others, but diabetes is pretty common. Um, so there's different types of diabetes. You have your type 1 diabetes, which, you will see. There's also the type 2 diabetics, right? What's the difference between type 1 and type 2?
Um, type 2, you could possibly like backtrack from it before becoming insulin dependent and get rid of it if you change like diet and lifestyle.
Okay. So type 2. Type 2 is potentially reversible when pre-diabetic, right? You change your
Type 1 is
lifestyle, your
autoimmune.
diet and exercise, you could potentially prevent it from moving forward to type to or to becoming or having to go on medications. Okay. What's type
Type
1?
1 is autoimmune. It's autoimmune. You're born with it usually.
Yep, so it's your autoimmune, right? They're insulin dependent. Type 1, we used to call this juvenile onset diabetes. However, it can occur at any age, but it's usually diagnosed before the age of 25. It's the smaller number of people within the diabetes community. Your type 2 diabetics, those are the more prevalent. And so, one of the risk factors for type 2 diabetes is increasing age. Um, so at some point, even as much as we try to control it with diet and exercise, at some point it just may not be able to be managed anymore that way. But before we go back or before we dive into more of diabetes, let's go ahead and take a break. Be back at 4:15. All right. So, with diabetes, what are some of the complications that we can see with diabetes?
Poor circulation.
Okay, absolutely. Poor circulation. What else?
Um,
I said, oh, sorry, I was muted. Hypoglycemia, like their sugar going too low.
Okay, so their sugar can go too low. Absolutely.
Hyperglycemia, too high.
Hyper. Yep. We can go too high or too low. Yep.
DKA, DKA, sorry, DKA, DKA.
DKA, diabetic ketoacidosis. Yep. If their blood sugar gets extremely high.
Can't just,
lower
Absolutely.
immune system.
Okay. Yep.
how about weight gain in
Oh,
certain parts of the body?
Weight gain.
You can lose
They have
limbs with diabetes.
Did we say
Mm-hmm.
poor circulation already?
Yep. Poor circulation. What else?
neuropathy.
Neuropathies,
Vision loss.
vision loss, retinopathies. Yep.
Glaucoma, that's what it was.
What about kidneys? What can happen to my kidneys?
The function would be compromised.
Yep. So we can develop kidney disease as well, right? So lots of
You see,
complications. Say
you'll
that
see a
again.
lot of them with like cardiovascular like disease and stuff.
Mm-hmm. So, yep, is a normal part of aging, with that arteriosclerosis or atherosclerosis, right? If they already have it and they have diabetes, it can increase that. It leads to poor circulation, right? And that poor circulation, right? Even a small cut, right, on a toe or a foot, can lead to huge issues for somebody with diabetes, right? They don't have circulation to allow for good wound healing. It can result in, the ischemia, which results in them having to get amputated. Um, so what are some of the risk factors? So type 1 diabetes we know is autoimmune, right? A lot of genetics, probably, or not probably, genetics and other things that are related to type 1. But what are some of the risk factors for type 2 diabetes? Obesity, sedentary lifestyle, if they have a family history of type 2 diabetes as well. Age is another risk factor too. Okay. There's age is going to be a risk factor for a lot of diseases, right? Because the longer that we live, right, the more at risk we are for developing disease. Um, so interventions. So if risk factors are obesity, sedentary lifestyle, and family history, what are some interventions that we would provide for our diabetic patients?
Exercise.
Okay, getting them up and moving. What else?
Blood sugar management.
Blood sugar management.
Education on nutrition.
Yep, education on nutrition, right? And if needed too, we need to get them to lose some weight, right? Because that can cause significant
So
positive
diet control, like food
changes.
restrictions.
Yep. Weight loss, right? Because it results in a decrease in glucose levels. It also helps with to reduce some of that insulin resistance that occurs with type 2 diabetes, right? And so that's usually the
What
first
about
treatment.
medications?
So the first goal of treatment, right, is going to be diet, exercises, and lifestyle changes. A lot of times,
Mhm.
and somebody said it earlier, if we can get those under control, a lot of times that A1C will drop, right? If they're compliant with their diet and exercise and weight loss programs and, alcohol in moderation, quit smoking, those kinds of things. A lot of times they don't need to get put on medication. They can reverse it. But yes, if their glucose levels don't get controlled with diet, exercise, weight loss, and lifestyle changes, then yes, we are going to add oral medications, right? So we'll add those oral anti-diabetic medications, right? Usually the first one we add is metformin, right? Really common medication. So yes, very good. Um, With your type 2 diabetics, it's usually oral diabetic, anti-diabetic medications. If those, then there are some injectable medications that we can use as well. They also can take insulin. If, nothing else is working, we can add insulin to their regimen as well. Type 1 diabetics always will be on insulin, right? Because they don't make any insulin. So we have to put those people on insulin. Hypo and hypothyroid too is something within the endocrine that we'll see with older adults. Primary hypothyroidism is more common in older adults than in younger persons. But it's either the thyroid gland is hyperfunctioning or it is underfunctioning. And so he will have some hormone or thyroid hormone imbalance. And so, sorry, I'm like choking. Um, so if you remember hypothyroid, right, your thyroid is responsible for your metabolic rate, heart function, muscle control, brain development, temperature regulation, growth and development, digestive as well as other functions. So when we look at hypo versus hyper, so my head, this is how I do it. Everybody knows who Eeyore and Tigger are, right? Okay. I think of Eeyore, and hyper, I think of Tigger, okay? Um, so with hypothyroid, generally they're going to gain weight. They're a little bit more slow and sluggish, right? Maybe constipated, have the slower heart rate. Um, with the hyper, right, they're a little bit, more tiggerish, okay? Rapid heart rate, weight loss, diarrhea, kind of like always up. Their metabolism is super high. Both of these can potentially be dangerous, right, for anybody. Both can develop a goiter, okay? So, a lot of times we think of hyperthyroidism and goiters, right? Because the thyroid gland is overproducing, it's going to get bigger. With hypothyroidism, it can still get the goiter because we're not releasing enough T3 and T4 into the body. And so that hypothalamus is like, hey, we need to get some more out there. So it's going to tell the pituitary to throw out some more thyroid stimulating hormone, which is going to the pituitary is going to stimulate that thyroid to try to get as much T3 and T4 out there. And the thyroid's trying, it's working, right? So it's getting bigger, but it's still not able to get those hormones out there. So the more that it's stimulated can cause it to grow. Um, and so both of these can have negative effects on the body. Um, Other things with hypothyroidism, dry skin, cold intolerance, lack of energy, right? It's where I get the Tigger. Um, and so we'll do, uh, we'll check their thyroid levels, their T3, their T4, as well as the TSH levels to try to determine what the cause is. And then we can give, right, necessary medications. What medication do we use for hypothyroidism?
Synthroid.
Level
Yep, levothyroxine, or Synthroid, whichever. Yep, they're same medication. Perfect. Good job. Anybody know what we do for hyperthyroidism?
Sometimes beta blockers.
We can do
Um,
beta blockers, absolutely, right? To counteract some of the symptoms. Good job. What else?
I was
We
gonna pull
do
this up and I forget.
It's okay. We can do like propylthiouracil, or we can do radioactive iodine to try to kill the thyroid, right? So that it slows down. Or in some cases, we will do the thyroidectomy, right? We'll go in and we'll take the thyroid out. All right, which brings us now to chapter 7, which is medications in the older adult. So problems related to medications, unfortunately, are very common in older adults. Um, and, we think of all the medications that are out there. Um, lots of, just the fact that older adults, may be taking a lot of different medications, which increases their risk, right, for interactions as well as your adverse drug reactions. So, what are adverse drug reactions?
Um, Anaphylaxis could be
Oh,
one.
okay.
Um,
Yeah, what you said.
Having
Are you asking
hypersensitivities.
to the thyroid med specifically or in
No,
general?
just medications in general.
Having hypersensitivities to any of the components in the medications.
Okay, hypersensitivities,
Toxicity?
toxicity, overdosing, underdosing, right? Drug interactions. Why do you think why are older adults more susceptible to adverse drug reactions than younger adults are?
Is it age
Lots of
related?
age related.
Our
So,
immune system is completely different. They're not able to. Mm,
Is it
no,
because like their body doesn't metabolize things the same? So like their dosage lives is different?
yep. So decreasing in kidney function, decrease in liver function, right? The two primary organs when we think of pharmacokinetics, right? The kidneys get rid of the drugs, right? So if my kidneys aren't working properly, then that means that the metabolites from that drug can build up in my body. If my liver's function isn't 100%, right, then the body is not metabolizing the drugs, right? So again, that increases the risk for toxicity. They also may be seeing multiple providers, right? So we know that as we get older, the risk for chronic disease increases, right? So if I'm seeing a cardiologist, an endocrinologist, orthopedist, a primary care, and I'm getting prescriptions, right, from a variety of different providers, right, and increases my risk for drug to drug interactions. Um, Overdosing, underdosing, right? All of those things are potential risks as we get older. So again, an adverse drug reactions and unintended, potentially harmful reaction to a medication. And so why are they all more susceptible? We talked about the physiologic changes, right? Those pharmacokinetics and pharmacodynamics, chronic diseases, hospitalizations, visits to specialists, um, and research bias. This is always a big thing. And so I'm going to go all the way back to, I don't know how much from pharmacology you remember. Um, but when we do research for new medications, right, the generally will use young college kids, or young college age people, I should say, in our, pharmaceutical studies when we're looking at new medications. They're generally healthy individuals, right? And so that is, who we do our studies on. And so, don't always, pay attention sometimes to those older adults. And so we have to be with that research bias, right? And there's lots of changes that go on with the older adults. And so use of multiple medications or even certain medications that may be safe and effective for younger people may not be safe and effective for that older person. So safe medication um, guidelines, we have the STOP, which is a screening tool of older persons' prescriptions. We have START, which is screening tool to alert to right treatment. We have Beers criteria, which is the list of medications that are potentially harm or the risk outweigh the benefits. There's so other medications that just here's, a list of medications that are some of the lists, not all of them, that are potentially more dangerous in your older, I'm sorry, in your older adult population. Um, in like digoxin, um, diuretics, some of your antihypertensives like your atenolol, your captopril, your psychotropics. We're very careful, especially with antipsychotics in the elderly population because it has led to sudden death. Some antibiotics are on the list. Some of the GI medications like the cimetidine, famotidine, can cause, confusion in the elderly and dizziness in the elderly. So we try to be really careful with that. Um, Examples from your stop. So kind of very similar to some of these, like with the cardiovascular system, like digoxin I mentioned. We have to be careful if they have impaired kidney function. Um, Beta blockers in some cases, tricyclic antidepressants, especially if they have dementia or glaucoma, not using the long-acting benzodiazepines. Um, with your start criteria, there's other medications that would be, still your beta blockers and other medications. So we try to be very careful with using some of these medications in the elderly population. Um, I can't remember what year it is, so forgive me. I'm not what year it is, not what year it was. But CMS guidelines made a huge push about medication reconciliation and decreasing the amount of medications that the elderly population are taking. You would do a med pass in a long-term care facility, and some of these patients are taking 30 medications for what, right? So there was a big push to reconcile all of the medications. All medications now, they have to have, when we remember those 9 rights of medication administration, right reason. All prescriptions from a healthcare provider have to have a diagnosis related to it. All right. If it does not, it either needs to be added or it needs to be discontinued. There's no ifs, ands, or buts. So we really look at those lists of medications and we try to get them off. It's the same reason why if PRN medications aren't utilized within 30 days, that we're going to take them off. They don't need to be on that PRN medication if they've not used it. Although I've come across that happen, and of course, the day after they discontinue the medication, right, is when we need it. But medication reconciliation is extremely important. So if you go back to pharmacology again and you remember the pharmacokinetics, remember pharmacokinetics is what the body does to the drug, right? And so the study of drug actions in the body, including the processes of absorption, distribution, metabolism, and excretion, right? So absorption is altered in the elderly population because of the decreased stomach acid, decreased peristalsis, decreased blood flow. Distribution is altered as well, decreased blood flow, right? Because that's what carries the medication to the site of action. Increased body fat results in storage of fat soluble drugs in tissues, right? So you they're taking the A, D, E, and K, right? Then they're more likely to have those build up in their body. Um, Decreased serum albumin affects binding of drugs, right? So especially your protein bound drugs. Um, Protein bound drugs, right? Um, they bind to protein, primarily albumin, because that's the largest protein we have. And whatever is not bound to protein is what we call a free drug. And the free drug is what actually can exert its action. All right. If I don't have enough albumin, then I'm going to have more free drug available, right? And more free drug available means that it could increase the risk for toxicity or overdose. Metabolism is decreased. We have decreased enzyme activity and blood flow to the liver, also decreased liver capacity. So, metabolism of drugs isn't done the same as it is in a younger person, which also increases the risk for toxicity. Excretion is decreased as well, decreased blood flow to the kidneys, decreased GFR, decreased number of functional nephrons, right? Leads to not being able to excrete the medications like we should. And that also can lead to overdose or toxicity. Um, we look at the fluid balance in aging. Older adults have a lower volume of total body fluid than younger adults, which also affects the distribution of medications, right? If I have lower body fluid, then the distribution of the medication to the body, right, is going to be altered. Um, Changes in body composition, lean muscle versus fatty tissue. So water soluble drugs remain in higher concentrations in the bloodstream because there is less total body water. And of course, dehydration will increase this effect. Fat soluble drugs get trapped in the fatty tissues. Decrease in plasma protein, talked about that. Talked about that. All right, so how do we know if a medication is effective? So we have an 80-year-old patient has been prescribed furosemide 40 milligrams by mouth per day for 2 weeks for hypertension related to congestive heart failure. What objective data could you use to evaluate drugs' effectiveness? So if we're giving somebody Lasix for her hypertension related to congestive heart failure, what objective data could we get to evaluate effectiveness?
Edema, swelling going down.
Okay, decrease in edema. Okay.
Maintenance in the body weight.
Okay, body weight.
They would probably have shortness of breath, so they wouldn't, that would get better as well as some of the fluid.
Okay, but is a shortness of breath, is that objective or subjective?
Oh yeah, you did say objective. I'm sorry.
No, you're good. You're good. Okay, but that would be my next question. What subjective findings, right? So decrease in shortness of breath, right, would be one of the subjective findings, right, that you would find. All right. So yes. So all of those, perfect. Then we have polypharmacy. So polypharmacy, right, is the use of multiple medications, right? Again, we talked about this. Could be for multiple providers, hospitalizations, outdated prescriptions, duplicate meds, lack of medication reconciliation. So some of the meds that I really things that you would that normally have to be changed or titrated. Warfarin is one, right? We may have to change the dose of warfarin because of the results of their PTINR. So they may have multiple warfarin prescriptions, right? Um, what else? Had another one on your thyroid medications may change depending on what your thyroid levels are. There's another one that was on the tip of my tongue and now I can't remember what it was. So they
What
may
about
have
pain meds?
multiples of these medications laying around, right, as they have changed instead of getting rid of them. Lots, and duplicate medications. Or, they were on one medication for their blood pressure and that wasn't working, so the doctor changed it to another one, right? The lack of medication reconciliation is extremely dangerous. And so this is a big push by the Joint Commission and the National Patient Safety Goals is that we do drug reconciliation with every visit within the healthcare system. So let's say they go into the emergency room. The nurses and the doctors in the emergency room should do a medication reconciliation. When that patient gets transferred up to whether they go to ICU or med surg, there should be another medication reconciliation that is done there. It should be done prior to discharge. Okay. And if they're going to a skilled facility, a long-term care, outpatient or rehab, whatever it is, at every point in that healthcare should be a medication reconciliation. Over-the-counter medications as well, herbals, supplements, vitamins, minerals. All of these have potential interactions with our over-the-counter medications. All right. And we need to know everything that they are taking so that we can potentially prevent some of these interactions from occurring. Cognitive and sensory changes also increase the risk for medication errors, right? So, they may not be able to interpret the labels and the directions. They may not understand how to take the medications, right? So that's part of our job is to assess their ability to read and understand prescription labels. And this isn't just for the elderly, and this could be it can be very true to the elderly. There are people in the United States that still cannot read and write. Okay, let that sink in. There are people still in the United States that cannot read and write. So if you're giving them written directions and written, education materials without assessing their ability to read, we have done our patients a misjustice or we've been unjust to our patients, right? So we have to assess their ability to read and understand prescription labels. And we also have to make sure that we're providing them in their native language. Okay, if they don't speak English, then giving them a prescription in English isn't helpful to them. Um, I was there was a case where, oh my gosh, was it digoxin? Maybe it wasn't digoxin. I can't remember the medication now. Um, it was a Spanish speaking family, okay, and the direction said once per day. ONCE. Once is 11 in Spanish. So instead of giving them one per day, they were given 11 per day and the child overdosed and died. Okay? Because why? We didn't provide the directions in their native language and they did not understand. So, huge issue. Yes, huge issue. Again, with inadequate knowledge, over-the-counter medications. Everybody uses over-the-counter medications, right? We buy Advil, we buy Tylenol, we buy cough and cold medications, all of that good stuff. They have to understand that there is a huge risk with certain medications, right? When we are providing them prescription medications. Excuse me. In some cases too, they over the counters can either create or mask symptoms of disease, right? Think I'm just having some heartburn, so I go to the drugstore, I get some antacids, or I buy some Prilosec to help my heartburn, right? Um, and it may help a little bit, but it's only, it's not curing anything. So if they have you know, ulceration in their stomach or in their small intestine, right? Um, Using alcohol with medications. Older people drink, guys. Right? They need to understand the use of alcohol in some of those medications. They may not know about the negative interactions with prescription drugs. So we have to provide that education. Financial factors. This is another big one. Medications are expensive. I don't know if anybody knows that. but some of these medications out here are crazy expensive. A lot of times we have older people that are living on fixed incomes that may have to make the decision to, buy their medications or keep lights on or buy food for their house. Okay. So taking that into consideration is really important. They may not refill prescriptions if they can't see the results or they don't have the money. Very important excuse me, to understand. There's couples, I've seen it. There's couples they're on the same blood pressure medication. The husband will take it one day, the wife will take it the next day, so that they don't have to pay for two prescriptions. They're only paying for one. This is something that we need to assess their financial abilities as well. So older client has been prescribed digoxin. The nurse determines at which age-related factors would place the client at risk for dig toxicity. So decreased elevation and GI motility, decreased muscle strength and loss of bone density, decreased lean muscle mass and glomerular filtration rate, or decreased cardiac output and decreased efficiency of blood return to the heart. Which one of those would put them at the biggest risk for dig toxicity?
D.
D.
Lean body mass and GFR. Remember, what's GFR is in the kidneys, right? So if my kidneys aren't functioning appropriately, right, then I'm not going to get rid of that medication appropriately. So it's going to build up in the body and increase the risk for toxicity or overdose. And I'm going to tell you, this is another one. And I came across this, and I know it's time, but I came across this the other day. So alendronate, and forgive me because I can't think of the trade name for it. But it's medication that we use for osteoporosis, right? And so I have quite a few patients or quite a few residents that can't swallow their pills whole. They have to have them crushed. Well, that's not a crushable medication, right? So I'm looking at it and I'm like, I can't crush this. I have to give it to them whole. What do you do? It didn't, and it wasn't one of those that you can dissolve either, like potassium, right? You can't crush potassium, but you can dissolve it in water, right? Um, so I literally took the pill and put it in some pudding and like we're gonna get this down, hopefully. But these are things that we have to take into consideration too, right? If we're giving clients extended release or patients extended release medications, right? They can't be crushed. What are some other ways that we can provide that medication, especially, or, is it in a liquid form or does it come in another form, that we can potentially get it down without crushing? But
IV.
say that again.
Said IV.